Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Okay. Shifting gears once again, we'll talk about some barriers to acceptance and adherence of long-term prophylaxis. This is a survey that was done in the U.S. It's over 400 patients asking about HAE quality of life, and it's actually a complicated survey, but I just want to point out, you see these different domains of how HAE can affect patients on the bottom on the x-axis here. And it's a little bit misleading because there's different scales to these different domains. I'll just cut to the chase. The three on the right are actually the places where we still, even in 2020 when this was done, have some deficits. Concern about offspring, perceived control over illness, and mental health. And that's because these were on the scales, which are different. These were much lower in terms of quality of life. So it's important, the point being that we still, despite the treatments we've talked about, we still have room to improve. We have room to improve the knowledge of HAE in the healthcare system, which is, of course, why we're doing these programs and why we appreciate you attending. We have to recognize the unpredictability of these attacks, and as Tim mentioned, the need for specialist expertise in most cases to really optimize health for our patients. And this is another factor that we have to consider with long-term prophylaxis. What are people most concerned about? Of course, patients want the prophylactic treatment to work, but they also have other concerns. And this is some work we did over the last decade, even more than a decade now, looking at 2010 compared to 2019. What are patients and clinicians worried about when they use long-term prophylaxis? And you can see in the old days, over 2010, it was side effects. That's because it was mostly androgens, and we knew there were side effect issues. Fortunately, that's come down, but now the major concern is, am I going to have access to the medicine? What's the cost? What's my insurance coverage? And to a lesser extent, things like route of administration and convenience. So it's been a dynamic landscape, and that probably will continue to change as we have new treatments.
Hey, Mark, there's a question for you. Sure. In relation to that. So the question is, are there financial support programs available? And since you're talking about it, I'll let you take a dive at that.
Yeah, there are. Of course, it's always complicated because most of those come from the manufacturers. So there are support programs for the cost of medicines and copay assistance. Where it can be more challenging is with government health plans where patients are not allowed to tap into manufacturer assistance. And so then patients and families have to turn to charitable organizations, apply for assistance, and there's a process with some limitation to the amount of funding from these charitable organizations. So the short answer is yes. The long answer is it's a little more complicated, and there is a process that doesn't work 100% of the time.
Yeah, and I think that's probably you have that as well. We have a nurse that's dedicated just to this process of getting approval of medications and finding funding access for those patients who are on them, because the cost of these drugs are prohibitive, even if you have to spend 10% copay. So,
yeah, exactly. All right, in the last few minutes, let me say a few words about investigational options, and I'm going to move quickly because we're running short on time, but this is a case of a patient, a 32-year-old gentleman diagnosed with HAE when he was much younger. He actually, as you see on the right, had a family history of HAE. He was on C1 inhibitor first IV for prophylaxis because he was a very active athlete, and that allowed him to wrestle and do well in his sport. He switched to sub-Q C1 inhibitor in college, and this has worked very well for him. But we recognize that therapy, while very effective, involves twice weekly dosing. He's now 32. We don't know the scenario, but he may travel a lot for work. He may have a job where it's difficult for him to adhere to that regimen. And we see that he's failed some other treatments. He didn't do as well on lanadelumab or berotralstat, which is not common, but we do see variability in effectiveness. So this is not an unusual situation where a patient is doing well on a drug, but has difficulty with either tolerability, the schedule, or sometimes the efficacy of a medication. And so that leads us to a question: which of the following is least important when considering options for long-term prophylaxis is optimal for a patient? So is it efficacy? Is it route of administration? Is it tolerance and adverse effects? Is it frequency and severity of the attacks prior to starting LTP? Or is it the ability to adhere to treatment regimen? And again, these may all be important, but which of them is probably the least important to focus on as you're discussing options with the patient? All right, so I would answer this as D, frequency and severity of attacks prior to long-term prophylaxis. And the main reason is we really haven't seen very compelling evidence that the frequency and severity of attacks predicts the response to any given agent, meaning that you can't pick out a patient, this is the best drug for them because they're having X number of attacks or this type of attacks. The drugs seem to be effective across the spectrum of patients, again, with some variability. So I think efficacy, route, of course, tolerance, adverse effects, and then, yes, the ability to take that medication on a regular basis. Drugs only work if they're taken as prescribed for the most part. So those would be the most important, not so much what's their baseline attack frequency and severity. Okay, so why do we still talk about new therapies? Well, I've sort of covered this. We want drugs to be as effective and safe as possible. We want the treatment burden to be as minimal as possible, and we want to improve access to these medications. So I'll run very quickly through some of the strategies, which include drugs that may last longer after a single dose, that are oral for patients that prefer an oral medication. We have additional targeted monoclonal antibodies, and then RNA interference therapies and gene therapies, which are not new to medicine, but relatively new to the HAE space. These are some investigational agents. I'll run through a few of these very quickly, but recognize there's some oral drugs like sebetralstat, which is for on-demand treatment, and deucrictibant, which is a B2 receptor antagonist being studied for both prevention and acute treatment. We have sub-Q drugs like garadacimab, a monoclonal antibody against factor 12A, and donidalorsen, which is a RNA interference oligonucleotide given subcutaneously targeting prekallikrein. And then a little further down the line, not as far in development, are CRISPR-Cas9 gene editing approaches and a long-acting monoclonal antibody, STAR-0215, that may be able to be dosed every 3 months and still remain effective for preventing attacks. And this is just a diagram showing you where those drugs work. The investigational drugs are in the light orange there. You can see they work in various targeted areas of this pathway: prekallikrein, factor 12, kallikrein, or the B2 receptor. So very quickly, I'll show you phase 3 data on, this is donidalorsen. This is the antisense oligonucleotide targeting plasma prekallikrein. You can see this phase 3 study has been completed and was recently published. 2 different dosing regimens, an 80 milligram sub-Q every 4 weeks or an 80 milligram sub-Q dose every 8 weeks compared to placebo. And you'll appreciate here that, again, over this 25-week study, on me, an 81% reduction in the mean monthly attack at the every 4-week dosing. Both of these doses statistically better than placebo in terms of preventing attacks. And you can see that 70% reduction or greater was met with 82% of the patients at the Q4-week dosing. 53% of those patients were attack-free during the 25-week study. And this looks like a very safe drug so far, mild or moderate events, and most of those being either injection site reactions, a few cases of headache, and nasopharyngitis. This is phase 3 data for garadacimab, monoclonal antibody against factor 12A. And you can see again, HAE type 1 and 2, parallel group, randomized, blinded study. Garadacimab is given with a loading dose followed by 200 milligrams sub-Q dose every 4 weeks. And again, in this 6-month trial, you see on the right an 89% reduction in the mean monthly attack rate compared to placebo. That 70% reduction or greater was achieved in 92% of the patients, and 62% of the patients were attack-free during the 6-month study period. Again, reassuring safety data. Most common adverse events were upper respiratory tract infections, nasopharyngitis, and headache. This is the oral deucrictibant. Now, this is phase 2 data, but also looking at preventing attacks, type 1 and type 2 patients. Smaller study is phase 2, but you can see 2 doses looked at, 20 milligrams a day or 40 milligrams a day compared to placebo. And again, this looks highly effective with the oral medication. You can see a mean reduction of 85% at the higher dose of 40 milligrams a day versus placebo. Also well tolerated. The most common adverse events here in this phase 2 study were some nausea, dizziness, and transient increases in GGT levels. This deucrictibant medication is also being studied as an oral treatment for acute attacks. And you can see the phase 2 trial data is in the green box. This was studied at 3 different doses, 10, 20, or 30 milligrams, given at the time at onset of HAE symptoms. And all 3 of those doses significantly reduced symptoms at a 4-hour time point compared to placebo. So this has now moved into a phase 3 trial as an oral bradykinin 2 receptor antagonist that may be effective to treat attacks at the time of onset. And that brings me to the last study I'll show you, which is oral sebetralstat. This is an oral kallikrein inhibitor, also studied for treating acute attacks at the time of swelling. Phase 3 study, you can see this 6-arm trial where patients were randomized to one of 6 sequences where they got placebo, and then 2 different doses of sebetralstat over 3 subsequent attacks. And so this trial, in fact, showed that this drug was effective compared to placebo. You can see the beginning of symptom relief was 1.6 and 1.8 hours with the sebetralstat versus 6.7 hours with placebo. And by a number of other measures, including the beginning of symptom relief, the reduction in severity, and the complete resolution, you see the responder analysis on the right, which in all cases showed significantly better results with the oral investigational drug versus placebo. Generally very safe, similar side effects in the active drug and placebo groups, and no serious adverse events. So that was a whirlwind tour of what's coming down the pike. I think it looks promising in terms of both our options to prevent attacks, additional effective and perhaps less burdensome options to prevent HAE attacks, but also perhaps easier ways to treat attacks with oral on-demand medication. And we'll have to see what the additional studies show and what the FDA decisions are on these investigational drugs. But I'll just wrap up by saying, think about HAE. We know there are delays in diagnosis that leads to both morbidity and unfortunately mortality. I want to emphasize this is a life-threatening condition, and unfortunately patients still die from HAE due to those airway attacks, particularly if it's not diagnosed or if they don't have adequate access to medical care. We know the goals of management are control of the disease and normalization of life, as Tim already talked about, and we have guidelines to help us design treatment plans using these options we've discussed. High variability in our HAE patients, which really in turn reminds us we have to individualize care. So we really need to talk through the options with patients, make sure the patient plan or the treatment plan is working. And we often have to shift things around, change that management plan over time based not only on how the patient's doing, but their phase in life. We know there are barriers to both identifying and treating HAE, and we've talked about a few of those. And then I hope I gave you a little bit of a flavor of what's coming ahead. Hopefully more effective, better tolerated medications that will, again, make life as normal as possible for our patients and families with HAE. So with that, we have maybe a minute or two for questions. Tim, I don't know if you had a look at these while I was talking.
I have a couple questions for you, Marc. So one is they asked about gene therapy.
Yeah, so the program that continues as far as gene therapy is the CRISPR-Cas9 program. This is a essentially CRISPR technology to knock out the KLKB1 gene, which encodes for plasma prekallikrein. And so far, there have been not a large number of patients, but I think they've reported at least 10 patients that have had this therapy in a phase 1/2 trial so far, and it's about a little over a year out that they followed this cohort of patients. It does look quite effective. The kallikrein levels are significantly reduced, and more importantly, these patients, for the most part, have stopped having HAE attacks over that year. I think on mean, it's about a 95% reduction in attacks. So that's a strategy that looks very promising, at least in terms of the efficacy. I think, I don't know what you think, Tim, but I think with gene therapy, it's always the big question is safety, right? What's the long-term look like if we edit a gene in this fashion? And so I think it'll be some time until we feel comfortable with the safety of this approach, but the early efficacy and safety results look very promising.
Yeah, I think diseases like hemophilia and sickle cell, where there's no other therapies, genetic therapies become more important. I think here in HAE, we have such good therapies that, I think we'll really have to wait for long-term safety to take those risks, since we have therapies that are so effective now. And especially in clinical trials that you mentioned. There is one other question for you, Marc, as they said, what's been the biggest change in your practice over the years, in the sense of improving barriers and increasing, care for the patient?
Yeah, I think the biggest change has been what you alluded to, Tim, is we are increasingly using preventative or prophylactic medicines. Rather than waiting for people to get sick, we're just trying to keep them healthy. And I think that's been a very positive development. The downside, as we talked about, is it can be challenging to get these medications and consistently have them covered. So as we already talked about, we have to pull in resources to try to make sure patients get the care that they need and deserve and in order to achieve, a normal life. So I think we have the tools now, but we still have to work within the system to make that work. I'll leave it at that, but I think it's an excellent thing to think about.
No, I think ditto on my part.
And I'll turn it back over to you, Tim, to close. But thanks, everybody, for your participation. I really appreciated the opportunity to present today. And thank you, Tim, for your collaboration.
Yeah, it's always a pleasure to work with you, Marc. Truly, thanks so much. And so I think that should be the end of our conference. And thank you for your attendance. And Marc and I are always available. Just reach out to us if you have a question about HAE. Have a great day. Thank you for joining us in the final episode of Patient-Centered Approaches to Long-Term Prophylaxis and Hereditary Angioedema. Please return to the landing page to access the downloadable slides and additional information.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.